I'm just going to spend a few minutes talking about engagement of the LGBTQ plus community. And I am going to share the stage with Ashby Dodge. Ashby was at Trevor Project. She is currently at National Suicide Prevention Lifeline. So I do have a few clips of Ashby, and I think she does an amazing job of stressing the importance of this conversation. So we're going to start with Ashby.
We work in suicide prevention and crisis intervention for LGBTQ youth ages 13 to 24. LGBTQ youth are lesbian, gay, bisexual, transgender, and queer or questioning youth. So when we look at suicide prevention for the LGBTQ community, lesbian, gay, and bisexual youth are 4 times more likely to attempt suicide than their straight peers. That's a huge, huge number. And we want to know why is this? Why is this group of people 4 times more likely to attempt suicide? LGBTQ youth are at highest risk just before and just after the coming out process. So if you're not familiar with what the coming out process is, it's acknowledging and communicating your gender identity and or sexual orientation, either publicly or privately. So if you think about the anticipatory stress of coming out, right? You're all this time leading up to it. What's going to happen? How will my family react? What will my friends say? How will people treat me at school? There's all of that stress leading up to the coming out process. And then after the coming out process, it's really dealing with that reality, right? What actually happened? What was the fallout? Who supported me? Who didn't? And really that possible loss of the support system. More than 1/3 will lose friends through the coming out process. So they're really losing that support system. LGBT youth who come from highly rejecting families are 8 times more likely to attempt suicide. And if you think of other LGBTQ specific risk factors like gender nonconformity or LGBTQ related victimization, perhaps bullying at school, this is a real problem. I'm Ashby Dodge.
So again, I thought Ashby did well just introducing the topic, not expecting us to leave here knowing everything, but hopefully we can just have an open, honest dialogue, and ultimately we'll leave here wanting to know more. So just briefly in regards to sexual identity, 1 in 5 youth identify as something besides gay, bisexual, or lesbian. So ultimately they're not fitting in those nice little boxes. And so just want us to be open to know that as we're talking to individuals, adolescents, young people, but it could be even someone, and I'll call myself older, it could be someone older, we may be presented with an identity that we're just not familiar with. Actually, these identities actually came off the Trevor Project website. They have an amazing website, and this is a very small list. And I'm not expecting you to know all these identities, not expecting you to memorize this list, just want you to know that they are out there. I actually had an experience with someone that was pansexual. So it was probably 1.5 years ago. I was with another organization and we were at a Pride event. And so everyone was just excited to be there, very affirming space. And we had a volunteer and she just kept talking about how excited she was to be at this event. And she also let us know she was going into her first year of college. And so again, we felt comfortable asking her, you know, what does pansexual mean? And she was gracious enough to be able to provide us some pretty insightful answers in regards to what it meant to her. And so again, for me, you know, I've been to trainings and I consider myself to be very open-minded, but it was a learning opportunity for me. And Ashby is going to further talk about her own experiences, her own personal experience, and then also how that applied in her professional work.
So when I first started working at the Trevor Project, I thought, coming from the gay community, I knew it all. I had it down. I understood all of the terminology and knew exactly how to approach everything. And it was a little bit of a rude awakening in the sense that I really didn't know as much as I thought. I had to learn a lot. So as we are working with this community, as we are working as clinicians, we need to say, what's the difference between gender identity, gender expression, sexual orientation, biological sex? All of these things are different, and they all kind of exist on this continuum, kind of parallel to one another. If we don't know what the differences are, we really need to find out, and we really need to educate ourselves. So when I first
thought this was a good example of, as much as we know, there's always opportunities for us to learn more. And just briefly in regards to sexual identity development, gender and sexuality develop across the lifespan. So just a reminder that it is a normative development, that oftentimes this is a time of exploration, and individuals can actually have changing needs over time. So again, we don't want to box individuals in. They may present as one identity, maybe when you're first meeting with them, and then a year, 2 years, 5 years later, they may present another identity. So in regards to shared decision-making, when I was preparing for this presentation, I wanted to talk about, or for us to think about, true engagement, things that were very practical. I imagine interventions that you're already using in your practice, even if you're not actually calling it shared decision-making. Laguerre et al. Defines shared decision-making as a process by which a healthcare choice is made by a practitioner together with the patient and is said to be the crux of patient-centered care. So again, I imagine most of you are doing patient-centered care, even if you're not actually calling it shared decision-making. And shared decision-making really is about educating individuals, discussing the options that are available, and then hopefully helping them tap into the power so they can make an active decision. In regards to the arrow is moving one direction, but I think it should be moving back the other way, because it can be a very fluid process. There are times that maybe something is just not available, or that you have to review that decision was made because the individual is not receiving the desired outcome. So what does shared decision really look like in day-to-day practice? And Demeester et al., they talk about how clinicians and patients are more likely to engage when it's just easier to do, when it's something they don't have to think about, when it's just part of the culture and it just becomes part of usual care. Because some barriers, when we're specifically talking about LGBTQ plus community, the cultural barriers, sometimes there's some distrust, and that might not have anything to do with you. That might be some experiences they had in the past or stories they've heard. I can think of a couple individuals that talked about individuals with a healthcare background, public health background, going to their own providers and being asked if they were sexually active. The question was yes. And then the next question was, do you use condoms? And the answer was no. And the one specifically talked about her provider just essentially going off on her about not using condoms. And so when we talk about that lack of awareness, the thing that had gotten her was that she felt that would have been an opportunity. Because if she simply would have asked her why, then she could have talked about that she identified as gay and she was not using condoms in her relationship with her partner. So again, we talk about that lack of awareness. Really, that can simply be an opportunity, again, just to ask the next question and just be in a place of learning. And another barrier in regards to shared decision-making can be so much focus on the patient-provider interaction. So it puts a lot of burden on the patient, on the provider. And so as we move through our presentation, we're going to talk more about how we can focus on some of the systems and the functions and the operations of the organization or the practice, so we can spread some of that burden throughout the organization. And Shelby is briefly going to talk about how we can start dismantling some of these barriers.
So we need to be able to provide culturally competent care, because if we provide that culturally competent care, folks will be more apt to seek help, to seek care, to seek resources. And then the care that they seek will be more appropriate. We want to look at using a strengths-based approach, a supportive teacher, a family member that is really accepting. Maybe the school has a gay-straight alliance that the student can become a part of. These are great things to look at and to really recognize, because it shows folks that they have these things in their life. They have what they need in themselves to overcome this situation or whatever they are going through in this case, and really look at, how do I get through this? How do I gain support? How do I decrease my isolation and see that I do have a community of people that care about me?
So how can we be that community that cares about the individuals coming through our doors? So we're going to talk about drivers of change. Demister et al. Talks about drivers of change. The first thing they talk about is workflow through the clinic. And I know time is of the essence. It's always an issue. I think it's just when I think about the individuals that have the bad experience, they eventually went to new providers. But it just took them a little longer to build rapport and to trust those providers, again, based on those previous experiences. So just remembering that something maybe that typically takes 1 or 2 appointments, or when you're thinking like, you know, why don't I have that individual's trust? It just might take a little longer. And then in regards to shared decision-making across the team, that doesn't always have to be a formal training. At the end of the presentation, in my references, all 3 articles are talking about specifically about shared decision making. Could be just reading the article, having conversations with other team members, just essentially so that everyone that comes into the agency or the office is receiving the same message from all team members. That electronic health record, and I did listen last time, and I remember some individuals still have paper charts, but regardless, I used to work with individuals and we would talk a lot about that health record, and they were very new to documentation. And there were times that I encouraged them to maybe pause before you write your case note, because language matters. And also I would remind them that it doesn't happen often, but individuals do have a right to access their record. So thinking about that, like, how would I write this case note, knowing this individual may read the record? I wrote front desk because unfortunately there have been times that individuals have been outed at the front desk. Want to believe that it was not intentional. Typically, I've heard it's happened around insurance concerns. So the individual is presenting with a name, and that name is in the record, but the insurance card might have a different name reflected. And that was another opportunity I can think of, you know, in regards to collaboration, the front desk staff, supervisors, case managers coming together and developing a plan. So again, if we're talking about operations, just where anytime maybe there's a delicate situation, that then the person is taken back and there's a private conversation. And pronouns matter. They matter to individuals. And if you're comfortable, I just encourage people to ask. If you don't feel you're at that place yet, I keep talking about Merriam-Webster in 2019 said the word of the year was they. So, I mean, they is very appropriate until maybe you get to that place where you feel like you can ask more questions around pronouns. Of course, leadership, staff commitment is important. You know, staff diversity, inclusion, equity, and, you know, really moving beyond diversity. So more than just the nice picture for the website and for any brochures, but really having a spirit of inclusion and equity. And I believe regardless of what our position is or the influence in our agencies, all of us can walk in that spirit. And then any relationship you can have with the community, if you have an advisory committee, a board, or just trying to plan an event, then, you know, thinking about, can I have individuals from the community as part of the process? Because I tell people, especially if you're even in a mid-size or a large organization, you have people on your staff that are part of the community. You have people that you're serving that are part of the community. They may not be out, which I think even is more of a reason for us really to be thinking about, you know, how we're portraying, you know, our role in the diversity, inclusion, and equity. Our physical environment, it matters. And in regards to visual cues, doesn't have to be a big pride flag. It could be, and that's okay. Or it could be just a small safe space sticker. Some of us here, we have safe space stickers on our doors. Restrooms have turned out to be controversial, and they shouldn't be since we all use them. But thinking about even intersections, of individuals. So many individuals are more than one identity. So on the other side of the wall here at Neomed, we have a gender neutral restroom, and it also has it's very spacious. So if someone is a wheelchair user, for example, then it also accommodates that individual, because you could potentially have someone that could be transgender, might use a wheelchair, and maybe they also need language services. So, you're thinking about your interpreting services. Are they sensitive to LGBTQ plus issues as well? So just also, as we're specifically talking about one identity, also thinking about the many identities that individuals might have. And there's that shared decision-making training again. So I must think it's important. And there's many resources available. Again, it could just be reading an article. If you go to the Ottawa Hospital Research Institute, they have decision-making guides available. And it's oftentimes when you talk about your cultural humility trainings, there's going to be an aspect of shared decision-making and person-centered care. And cultural humility training moves a little beyond cultural competence. So again, when I think about myself and any trainings I've gone to, say in the last 5 years, then they weren't talking about pansexual. So when I talked about our individual at the beginning and she was excited about being at the Pride event, so that was an opportunity for me to be humble, to step back, and again, just to be in a place of learning. And I am going to allow Ashby to have the last word in this part of the presentation.
If you think you're doing the best you can, I would challenge you to be better. Learn the terminology, understand the LGBTQ community, understand that one young person who thinks that no one is there for them. You can be that person that's there for them. You can be that person that understands and doesn't judge them and doesn't make assumptions and says, I see you and I hear you just the way you are.